And in this topic, we're going to cover health information management and data management. So in 2008, the chair of the Australian Health Ministers Conference said, at its core, health is a knowledge industry, with information being central to all aspects of care planning, management and delivery. And this is really important because information and information management is a priority for you as health services managers. And most HSMs get to use information without thinking too much about how that information came to be there, and also how accurate it is or what the cost is in actually providing that information for you. So in Australia at the moment, the National eHealth Strategy is in progress. It's a plan to develop and agree to national standards to build the underlying technology and put incentives in place to encourage the implementation of that technology. It's also going to be used to provide governance and the management and structure to do things that ensure data of patients is kept private, that bills to cover costs and allocate systems are all the same, and that this whole system can be one comprehensive, holistic system. And if you want to look up anything about the eHealth strategy, you'll find it in this document, the eHealth strategy for New South Wales Health, 2016 to 2026. So the eHealth, summary looks primarily at clinical systems and systems that will enable patients and clinicians to access and use clinical information. But health information infrastructure is about much more than just clinical systems. Like any other business, it has financial systems, human resources, security systems, purchasing systems, asset management, and heaps and heaps more. So currently, the health information is probably best described as information islands. So things are very much individualised in particular categories. So, and this quote expresses that quite well, that currently health information landscape is characterised by discrete islands of information with significant barriers to the effective sharing of information between healthcare participants. It poses challenges when trying to understand and report on what is really happening to support population health surveillance and to guide policy, and also to guide service planning, innovation and clinical and operational decision making. And this comes out of Lee's book, Lee's chapter, which was also cited in Barker and Coy, The Power of Culture, Driving Today's Organisation, Australian Institute of Management. If you can get your hands on this article, it's actually a really good one to read because it explains how diverse the information systems are across the Australian health landscape, if you like. So this information silo problem in clinical areas is the concerns of the eHealth report, but the problem is a long-standing one. It's always been a difficult thing to address, and it causes causes problems in other areas as well. It's not just in the clinical areas. But in October 2008, all the area health services across New South Wales started to use a common chart of accounts. So that's the rules for the way cost centres are structured and how costs are allocated to those cost centres. So this is the beginning of actually making things standardised across the state. And as you can imagine, there's been a number of hospitals closed down or changed into different sorts of hospitals. And so in the old days, each little hospital had their own system of billing patients and getting money in and distributing money around. So it's been a really long-standing issue. The bigger problem for clinical costing is that human resource systems talk to financial systems, but it's difficult to know who gets paid what because of the different layers within the HR systems. The HR systems don't actually talk to patient administration systems. So these are the systems that allocate patients to doctors and wards, for example. So when a patient goes into a hospital, they're allocated to a particular area. That's a patient administration system. But the way the staff are paid it doesn't talk to that system. So there's no way of knowing which of the nurses, and of course they're all paid at different rates depending on how experienced they are, and some casual staff, did what to which patients when. So this is a big problem of actually working out what it's actually costing us to provide care for a particular patient. So at the moment, the patient costing systems use what's called cost modelling, and this is formula worked out from activity studies to allocate ward level costs for individual patients, but it is not a perfect science. So when people started to use computers for other health-related activities, things like looking at disease indices or looking at pathology information, it became evident that the structure of data was critical so that we can actually know what data we've got and what information it's going to give us. This is critical for several reasons, but the most important was that the computer storage space in those days was prohibitively expensive. So every single byte had to be used really carefully and really effectively because there wasn't very much storage space. So what happened was the disease index list was developed, and this is kept by a hospital of all the people that had a specific diagnosis. And in the beginning, the disease indices were kept in lists, with the lists headed by the diagnosis, and then under that were recorded the name of the patient and the date and the doctor and any other information that the hospital decided that they would keep. Now, these were really labour-intensive type documents to keep, and so they were also difficult to search. So when researchers wanted to track back as to see who had what, it was really difficult to actually find who had what in these long, long lists. So there then introduced was the International Classification of Death and Diseases. It's now called the International Classification of Diseases, the ICD. And this meant that the diagnosis could be given a code rather than in words. Once the disease didn't have to be written out in full, and the patient's name could be replaced with the patient's medical record number, for example, the context was then in place for automation. And we now use the ICD-10, the International Classification of Diseases, Australian modified, which has got the AM after it, so ICD-10 AM. And this is the coding system that we use in health. So metadata is information about data. This is huge, big stuff. We sometimes hear the term big data as well. So in the disease index example, the term metadata includes both data dictionary and the data structure. So a data dictionary is a document that lists all the data items, so the variables or the data elements in that particular database or in that data set. It defines each data item and the domain of that data item. So an element's domain is a list of all the items. So these are code values, for example, that may be entered into that particular data element. So if you have come into hospital and you are having an appendicectomy, so you're having an appendix taken out, all that will be coded. The age that you are will be entered in, and all the information about you and your surgery will be coded. So a disease would be listed as a principal diagnosis, so you might have an infected appendix, which would be given a code. A secondary diagnosis, there might be something else. You might have a cold as well. And there'd be a definition of what constitutes a principal diagnosis. So this is what is it you're coming into hospital for, is your primary diagnosis, and your secondary diagnosis might be something else that you have as well. So the domain of the diagnosis will be defined by the codes in the ICD-10 with fields for a principal procedure. So your procedure would also be coded. So you would have surgical removal of appendix would also be given a code. And then there might be a number of secondary procedures. You might have a catheter inserted, you might have a cannula inserted, there might be other procedures that you go through, and all these would be coded into the data set. Pardon me. In terms of data quality, the information quality is actually a business problem, not an IT problem. So it's really important that the information quality has to be a business solution, not an IT solution. So that means the person that codes the data is the person that is critical. And you'll often hear people saying, it's really hard to be a clinical coder, because clinical coders have to know an enormous amount about the coding systems, about the patient data that they're looking at, so they can code the data correctly. So, for example, it's possible only to give the option of selection from a drop-down list with many different causes. So if there's lots of root causes of problems, including the process, the procedures and the training, all these things have to be included. And the solution to data quality issues begins well before the software. It's really important about knowing exactly what it is the patient's there for. So the cost of data errors is significant because the health districts are funded directly in relation to the services provided and their cost. So we know, for example, how much an appendix, a surgical removal of the appendix costs, and how much that is going to be, how much funding will be given to that hospital to do that sort of procedure. So it's really important that we have all the stuff entered in. All that data has to be in there. So the data has to be collected to standard definitions for national and interstate and international comparisons. Otherwise, you're not comparing apples with apples. You're comparing different things if the data is not consistent. And while it may end up being used internationally, the data collection process starts from information that's collected from individual patients or staff members that actually keep that data and code it properly. So who uses all this data? Well, at state level, the data is incorporated into measures that drive clinical policy and payment systems to hospitals and area health districts and local health districts. At a national level, the data may turn up in collections like cost data collection, health expenditure reports, so the Health Expenditure Australia or any other numerous reports that are produced. So the Australian Institute of Health and Welfare reports on Australia's health each year. This is where they get their data and this is how they manage it. So there are some issues to resolve. Underlying infrastructure is still not up to speed. The connectivity and the bandwidth varies very much from area to area. The communication between products is not there quite yet. So, for example, a GP working in the community can't check on data in the hospital, for example. He won't know where his patient would be. There's not that sort of connection yet. In terms of classification and coding, there are still some international differences there. So, for example, with chronic obstructive pulmonary disease, we might use the code, one code. Other parts of the world call it chronic obstructive lung disease. So it's actually named and may be coded differently. We need to make sure that the data is secure completely, ensuring that the doctors can actually sign each time they access information. So if this is all housed on massive computer systems and networks, anybody who accesses that has to have authority to access it and leave their electronic fingerprint on that data. Otherwise, the data is not secure. So we need to have reliability, availability and serviceability. And this is difficult because maintenance needs to occur on hardware, of course, and on software updates and upgrades. But health data, of course, needs to be available 24 hours a day. So it's very difficult, when do we turn it off to actually, do maintenance on the system. And maintaining privacy between doctor and patients can also be another sort of issue, because sometimes a patient may talk to one doctor about a particular issue that they have, but they may not talk to all their doctors. So, do they give permission for that information to be shared among all health professionals, or is that something that needs to remain private? And this is an issue that needs to be resolved.